Hello, and welcome to this JAMDA author video presentation. I'm Dr. Sheryl Zimmerman from the University of North Carolina at Chapel Hill, Cecil G. Shep Center for Health Services Research. I'll be discussing the article entitled, Can Sepsis be Detected in the Nursing Home Prior to the Need for Hospital Transfer?, which is published in the June 2018 issue of JAMDA, the Journal of Post-Acute and Long-Term Care Medicine. To get us started, let's consider that sepsis is a major source of morbidity and mortality among nursing home residents. In fact, you may find it interesting to learn that in emergency departments, nursing home residents are 17 times more likely to be diagnosed with sepsis than patients from other settings. And while rates of intensive care use and mortality are high for patients with sepsis, early treatment reduces both morbidity and mortality. Our research team sought to determine if it was possible for nursing home staff to effectively identify persons who were developing sepsis, so the treatment could be initiated early, perhaps even in the nursing home. To answer this question, we took advantage of several screening tests that have been developed to identify incipient sepsis, but none of which have been tested in nursing homes. We therefore sought to compare these screening tests when applied 12 hours before and 13 to 72 hours before a nursing home resident was sent to the emergency department and diagnosed with sepsis. The research was conducted as part of a study of infections in 31 community nursing homes in North Carolina. We retrospectively compared chart data for 59 nursing home residents who were hospitalized for sepsis with data for 177 residents who were hospitalized for other non-sepsis diagnoses. Specifically, we evaluated 5 potential screening tools: the Systemic Inflammatory Response Syndrome, or SIRS criteria, the Quick Sequential Organ Failure Assessment Tool, otherwise known as the QSOFA, the 100-100-100 Early Detection Criteria, a temperature of 99 degrees Fahrenheit or higher, and a temperature of 100.2 degrees Fahrenheit or higher. Each of these measures primarily uses vital sign data, although both the SIRS and QSOFA add other parameters. This table summarizes the 5 tools we evaluated. Details are included in our paper. Now let's look at what we found. When we examined documentation during the 12 hours prior to transfer from the nursing homes to the hospital, we found that at least a quarter of cases in both the sepsis and non-sepsis groups didn't have all vital signs documented, and that fewer than 1 in 5 nursing home residents saw a medical provider before being transferred. Our data on documentation 12 to 72 hours before transfer were similar and are reported in the manuscript. When we compared the 5 potential screening tests, we found that none of them did a great job identifying residents with developing sepsis. The best was the 100-100-100 criteria: a temperature of 100 degrees Fahrenheit, which is 37.8 degrees Celsius or greater, a pulse of 100 per minute or greater, or a systolic blood pressure of 100 millimeters of mercury or lower. But even that tool only identified 31% of presepsis residents in the 12 hours prior to hospitalization. The second best was a temperature greater than or equal to 99 degrees Fahrenheit, which is 37.2 degrees Celsius. Sensitivity and specificity at both time intervals were best for the 100-100-100 tool, and second best for the temperature cutoff of 99 degrees. This relatively low temperature reflecting the fact that the average nursing home resident has a normal body temperature of 97.7 degrees Fahrenheit. The generally modest specificity and sensitivity of all of these tools reflects the fact that virtually all nursing home residents are chronically ill, and that the classic signs of infection are frequently absent. In conclusion, we determined that an effective nursing home sepsis prevention and early detection program will require several changes to current care practices. At minimum, all 4 vital signs need to be measured routinely and regularly on every resident for whom staff notice a status change that could constitute an early sign of infection. The vital signs then need to be incorporated routinely into sepsis screening by using the 100-100-100 early detection tool and/or a temperature threshold of 99 degrees Fahrenheit, or 2 standard deviations above that resident's normal body temperature. Additionally, and this will be a big change, an in-person or virtual visit with a medical provider made within hours of a positive screen is suggested. Finally, rapid diagnostic testing and results for markers such as the white blood count, serum lactate level, and possibly serum calcitonin would need to be available. Based on our findings, we suggest that a protocol incorporating all of these elements may reduce hospitalizations for sepsis while improving diagnostic and treatment time for patients with true sepsis. And we consider further research into practice changes that would make this capacity possible to be considered a priority. Thank you for listening. For further details, please refer to the article in the June 2018 issue of JAMDA, the Journal of Post-Acute and Long-Term Care Medicine, which is available at jamda.com.